Hello, I'm Professor Simon Lewis at the University of Sydney, and it's my great pleasure to have the opportunity to present to you today. Before I go into the presentation, I just want to put up this small disclaimer to say that I might talk about medications, but this isn't medical advice. So in actual fact, you need to discuss these things with your specialist. So as I say, I'm going to try and cover the management of the non-motor features in multiple system atrophy. And so I have to give great credit to a couple of papers that I found in my preparation for this lecture. One came out a few years ago, and one only came out just earlier this year. And I'm very grateful to the authors for all of their wonderful advice. And I advise you, if you're a medical professional, to go and have a look at these references. What I'm going to try and cover amongst these non-motor features is things like blood pressure control, constipation, bladder disturbance, erectile dysfunction, drooling of saliva, breathing disorders, sleep problems, and mood disturbance. So there's quite a lot for us to get through. It'll be quite quick, but that's why we're recording it, so you can go back and visit things again. So we'll start with blood pressure, and obviously the main problem we see in multiple system atrophy, or MSA, is postural hypotension. You stand up and your blood pressure drops down. So the first thing we do is to review the medications. And so there are a number of people who are a bit older who might be already taking blood pressure lowering tablets, and they need to stop. And then, of course, with the physical part of multiple system atrophy, one might be on levodopa medications, and these can lower blood pressure. So we have to think about whether they can be adjusted. The other things we do are, if you like, non-pharmacological, so making sure that people are well hydrated, so drinking plenty of fluid so that the circulating volume of the blood is good. Increasing the dietary salt. Whoever knew a doctor who would tell you to have more salt in your diet? But what happens then is your blood becomes salty, your kidneys get the instruction to retain more fluid, and that again increases the circulating volume. One of the tips that I think is useful is sleeping with the head of the bed raised. So you feel as though you're slipping off the bed, but about 30 centimeters, about a foot, with the head of the bed raised. And over the course of a few weeks, this can improve the control of blood pressure through the day. Compression stockings, so the sort of things that you might see in people who have got post-surgery, those tight white stockings, or the ones who go on long-haul flights. Not always easy, especially if you're in hot countries. And then more recently thought given to elastic abdominal binders. So these are the sorts of Velcro and elasticated strapping that you might see people like athletes or weightlifters, where they strap it around their tummy very tight, and that allows them to brace, and that allows more blood to get to the brain and stops people from fainting, is the plan. What about medications? Well, there are some old drugs. There's a drug called fludrocortisone, and this is a drug that tells your kidneys to retain salt, and that, of course, then prompts the kidneys to retain more of the fluid so that your circulating volume goes up. Pyridostigmine is probably the drug that I tend to use first, and it's said to work on the blood vessels, causing the blood vessels to constrict, and only when people stand up. So when people are lying down, it shouldn't be that active. Next drug that we can see used is a drug called midodrine, and midodrine is a prodrug. So it gets broken down into a chemical that stimulates adrenoreceptors, which are again on blood vessels and cause blood vessels to constrict, increasing the tone of the muscles, and the blood pressure it goes up. And then finally, there's a drug which isn't licensed everywhere around the world called droxidopa. And again, this is a prodrug of adrenaline and noradrenaline and can cause that vasoconstriction that we're looking for to try and keep the blood pressure up. The only thing I would say about these drugs, apart from pyridostigmine, the other medications will all put your blood pressure up all of the time, which may or may not be a good thing, because we do see patients who develop a thing called supine hypertension. That is to say, when you lie down, the blood pressure goes too high, and this can cause damage. Obviously, we know that treating blood pressure reduces your risk of heart attacks and strokes and things like bleeds. So it's something we need to monitor. However, having said that, I think one has to balance the risks between someone fainting and injuring themselves, maybe breaking a hip, bruising their brain, versus that small risk of having a bleed in the brain or damaging the end organ like kidneys and the eyes, for example. So I think this has to be weighed up. So I think most of my patients, I tend to prefer their blood pressure to be a little bit on the high side and not fainting. In terms of other sensible advice, try and avoid lying down after you've had one of those medications that boost your blood pressure. Again, raising the head of the bed overnight, because of course it'll actually take the pressure off the brain. So that's not a bad thing. And then perhaps using a short-term antihypertensive. So a thing like a GTN patch, where essentially you stick it onto the skin. And this is a drug that's often used for angina. But the good thing is it causes dilation of the blood vessels. And for that period you're wearing the patch will therefore lower the blood pressure, which means that if the blood pressure comes back down to normal after a few minutes or half an hour or so, you can take the patch off and hopefully things will stabilize. One of the other thoughts that people have raised is the idea of having a heavy carbohydrate meal before going to bed. And that's thought to perhaps reduce some of this supine hypertension, presumably by diverting blood from the brain to the stomach. The next topic I want to cover is constipation. Constipation, a massive problem in MSA. And there are some simple approaches that I think people need to be aware of. So increasing dietary fiber is critical. Increasing fluids. So we just heard about keeping your blood pressure up by being well hydrated. Obviously, a number of patients are concerned about how this will impact on their bladder, but all of the drugs we're going to talk about a bit later on for constipation require fluids for them to be more effective. Exercise is important, and that helps to regulate the bowel habit. And routine habits. So setting yourself up to say, okay, I'm going to try and open my bowels at specific times, maybe when I first get up, maybe after I've eaten, and to try and get a routine bowel habit going. And do not ignore the urge. So if there is, if you like, an urgency to empty the bowel, then rather than holding on, which is what we might do ordinarily, you should actually ride that wave, so to speak. In terms of our approaches, as illustrated here in the diagram, we've got things that can change the stool, if you like, and the way that things move through the gut. So bulking agents, things that soften and lubricate, osmotics, which draw fluid into the lumen of the gut, and stimulants that allow the gut to move. So bulking agents. So we're thinking about things like metamucil, which psyllium husk, benefol. These are vegetable fibers from the chicory root. They all require fluids because the fiber draws fluid to it, softening up the stool. And these are a maintenance treatment approach rather than a treatment to cure constipation. This is something you should be on all the time at a low level because they take about 2 to 3 days to work. Softeners and lubricants. So these are things like Coloxal, and these draw fluid and fat into the stool, again, softening them. This is a maintenance therapy that takes a couple of days to work. So it's not something to rescue someone who's very constipated. And again, it needs lots of fluids in the diet. Osmotic agents, so these can come in various forms. So oral, so these are things like Movicol, sorbitol, lactulose, Epsom salts, and these take again a few days before their effect is felt. There are more rapid approaches, so things like a rectal suppository, a glycerol suppository, and this can act very quickly and is sometimes a useful way of getting the bowels kick-started. For chronic constipation, these are the approaches that, one has to be careful about balancing up with those more regular treatments. And they work by, again, drawing water content into the lumen of the bowel and softening things up. They can also cause some contraction, and so some patients can get cramping sensations, so you have to be a little bit careful about their use. And what about stimulants? So again, these can come as oral medications, so Dulcolax or Senna, usually combined with Coloxal, and these are a bit quicker to act. They usually act in a few hours. And then there are rectal approaches to stimulants, such as the phosphate enema, which can be used for very severe constipation, causes a dramatic increase of fluid in the rectal cavity, causing distension and then the triggering of defecation. More recently, people have looked at other approaches with things like secretagogues and prokinetics. So secretagogues, lanaclotide would be one, and it stimulates specific receptors in the gut to increase intestinal fluid secretion. So if you like, softening things up. And then the other approach is prokinetics, of which prucalopride is an example, which again stimulates specific receptors in the gut and increases the contractility, so peristalsis, the wave that makes the gut move stools along to improve motility. And although we don't have great trial evidence to support the use of any of these treatments, same with blood pressure, same with all the things I'm going to talk to you about, There are reports, and this is from a group in Toronto, a well-respected group, suggesting that these drugs can be used in patients with Parkinsonism, and this study actually did include patients with MSA. So there are things to discuss with your specialist if you're running into trouble. The other thought is that there is literature emerging now from the Parkinson's community suggesting that probiotics, so the good bacteria, if you like, can be used. And in Parkinson's disease, there are a couple of studies, both out of Malaysia, interestingly enough, that showed that probiotics could improve constipation in people with Parkinson's disease. Now, we don't have the same level of data in MSA, but it's again something that can be considered and, of course, relatively easy to access worldwide. So we're going to move from constipation to the bladder, and we have problems with the bladder such as increased frequency, where you have to go many times, urgency, where you can't hold off emptying the bladder, and then things like hesitation, where you get there and you can't get the bladder emptying. And then there are obviously very important aspects that are not to be overlooked, such as stress incontinence, usually more common in women, especially if they've had a number of children, associated with prolapse. And prostatism, so older men getting swollen prostates, either benign or related to cancer. So these are things that we should be looking for in all of our patients with MSA, because they are not going to help the bladder's function and they are potentially treatable. The way that the bladder works and connects to the brain is very complex, not terribly well understood, but I'm going to talk you through the approaches that we use in terms of our treatment. So the first thing is going to be a urological review. We don't want to miss a cancerous prostate or prolapse to be treated. And then there are simple strategies like rehabilitation. So we do physiotherapy for your balance, but we also can do pelvic floor exercise for your bladder. And then there are a range of medications that work in different ways, as well as other interventions. And we'll talk about those over the next few slides. So anticholinergic medications, so these are things like oxybutynin, tolterodone, and these work through acetylcholine receptors in the nervous system, and they suppress the muscle that contracts and empties the bladder, so it reduces that overactivity. However, these receptors are also found throughout the rest of the body, especially in the brain and in the salivary glands, so they may cause things like dry mouth, a confusion, and also if they work too well for the bladder, they can put you into retention. Tricyclic antidepressants are medications that were designed for depression, and these things like amitriptyline, and again, these have different activities. Sometimes, some of their action is through adrenergic receptors in the sphincters of the bladder neck to enhance bladder neck resistance. But also they have anticholinergic properties that can suppress that bladder contraction, a bit like the other drugs we just talked about. So therefore, they can come with a range of side effects, just like we've heard in relation to the anticholinergic medications. More recently, we're seeing these other agents like mirabegron, or otherwise known as betmega, and a selective alpha adrenergic agonist, which works on the receptors in this muscle of the bladder, the detrusor, and causes muscle relaxation, allowing the bladder to have increased capacity. And I think these do carry less in the way of side effects. So I think that they are more my go-to in terms of treating patients, unless you're looking for another benefit, such as too much saliva, which we'll talk about soon. Antidiuretic hormone is a way of telling your kidneys to retain more water, which again reduces, if you like, the number of times you need to empty your bladder. But this again can come with side effects like increasing fluid retention and confusion. So not a commonly used approach. And then more common is the idea of injecting directly into the bladder. And the commonest thing here is Botox or botulinum toxin, again, to target the detrusor muscle, to paralyze it. And this can have a prolonged activity. Sometimes it can last as long as 12 months before people have to have procedure repeated. However, occasionally it can be too effective, and this may result in temporary catheterization. Often what you'll find doctors do is to use a very small dose for the first time they inject the bladder to see if there's an effect, and then essentially gauge how big the dose needs to be to get a more prolonged and sustained benefit. Capsaicin is pepper, as you know. There's a little bit of research evidence suggesting this may be useful for bladder control, but again, not much real randomized control data. Catheterization is something that we need to consider in terms of reducing urinary tract infections, which of course can result in going to hospital. So if somebody has a post-void residual volume, so empty your bladder and then an ultrasound, have a look at how much urine is left in the bladder. If there's over 100 mils, that's quite a risky level and may be associated with urinary tract infections. And this is the sort of thing that might stimulate us to have a conversation around intermittent self-catheterization if the dexterity is good enough, or the placement of a permanent suprapubic catheter to drain the bladder, which may result in less infections, although of course has to be managed with its own potential for blocking and infections. The other thing that I came across, again, from the Parkinson's literature is the idea of bladder training. So urge suppression, pelvic floor exercises. And again, in the world of Parkinson's disease, there's evidence to suggest that this may be beneficial for people with lower urinary tract symptoms. And although we don't have the data in MSA, I think it's again something that should be considered. Erectile dysfunction, obviously very common in the male MSA patients. We do have recognized treatments like phosphodiesterase 5 inhibitors. So this is sildenafil, Cialis, Viagra. These dilate blood vessels and therefore can be associated with hypotension, so have to be used a little bit carefully. And then the other thoughts after a specialist consultation with the urologist is the idea of things like intraurethral suppositories or intracavernosal injection, so injecting into to try and stimulate an erection, or use vacuum-assisted erectile devices and banding at the base of the penis to maintain an erection. So we're going to move on to the problem with saliva, and this is generally too much saliva, so drooling of saliva. So the simple approaches are to stimulate swallowing with things like lemon bonbons or sugar-free lollies if you're diabetic. But one of the easiest approaches I've found is to use an aerosol Atrovent inhaler, which is a drug that's typically used for patients with emphysema or chronic bronchitis, where it's inhaled onto the lungs. But in actual fact, what it can do because of its chemical activity is block the activity of the salivary glands, and therefore, used a bit like a mouth spray, it can be useful. Atropine eye drops are used on the eyes, but in actual fact, if you make up a solution and gargle it, it can also block the activity of those secretory glands in the saliva, making glands in the mouth. We mentioned some of the drugs that can cause side effects of dry mouth, like tricyclic antidepressants, so they might be beneficial here, and other drugs like antihistamines, and also injecting, again, with botulinum toxin into the salivary glands can be effective to reduce those muscles that are secreting saliva out into the mouth. But again, one can be one has to be a little bit cautious about triggering problems such as weakness of the swallowing muscles and also the neck muscles. So this might precipitate someone needing a feeding tube, or they're not being able to keep their head upright. So we have to be a bit careful about using botulinum toxin. What about other problems? So bulbar difficulties. So this is swallowing problems. So I think it's very important that people are engaged in speech therapy assessments, because this can be helpful in terms of improving the strength of those muscles. But occasionally patients do require a feeding tube or a percutaneous endoscopy, which essentially comes out of the stomach and allows us to feed people. Whether there's good evidence that that reduces aspiration going onto the lungs, I think, is harder to prove, but in terms of maintaining nutrition and hydration can be useful. And of course, speech therapy for speech, because people become soft and become slurred, and it's one of those problems where you can't leave it. So in actual fact, once the speech is very severely affected, doing speech therapy is often unhelpful. So therefore, you have to start this very early before things get bad. What about breathing difficulties? Well, we see things like central and more commonly obstructive sleep apnea. We do see changes in breathing patterns and breathlessness, as well as occasionally where the vocal cords come together when they shouldn't. There's a contraction there, a dystonia, and that can cause a blockage of the airway, or what we call laryngeal stridor, where people are struggling to get air into their lungs. So how do we treat these things? Non-invasive ventilation, so basically putting positive pressure on the airway to keep it open, things like CPAP and BiPAP. In more extreme cases, tracheostomy to make an airway that wouldn't be compromised. And also in those cases with an overactive muscle in the larynx, botulinum toxin injections can also help relax that and open up the airways. Sleep disturbances, unfortunately, are very common. So things like fragmented sleep because of the bladder or the bowels, breathing problems, discomfort, and also a more if you like, nebulous symptom is that of dream enactment or REM sleep behavior disorder, which we see very commonly in people with MSA. And this is a video taken from the Mayo Clinic of a patient who is in dream sleep and they act out their dreams. So normally there is a mechanism in the brain that doesn't allow you to do this, but because of the pathology in MSA, we see this dream enactment behavior quite commonly, and unfortunately it can result in injury, not only to the patient, but also their bed partner. And unfortunately, the drugs that we typically go to, things like clonazepam, benzodiazepine, has been trialed not in MSA, but in Parkinson's disease, where they also get this problem and didn't seem to work. And similarly, melatonin, a trial done in my center in Sydney, again in Parkinson's for REM sleep behavior disorder, didn't seem to work. So although we have these drugs, I'm not sure that they're as effective as we would like. So we look at sleep problems and review the motor symptoms, make sure people are comfortable, and then practice things like relaxation techniques, massage, safe bed environment. So finally, I want to come across mood disturbances. So these are very common problems, and I think we always want a non-pharmacological approach first. So counseling, not only of the patient, but also their caregivers can be very helpful. And then there are medication choices that are out there, which we'll just whip through. So the selective serotonin reuptake inhibitors and the selective serotonin noradrenergic reuptake inhibitors are common medications, fluoxetine, venlafaxine, that are used to treat depression of any kind. They seem to be well tolerated, and there is actually small amounts of trial data in multiple system atrophy suggesting that it may be beneficial for mood, these drugs, with the trial being done in fluoxetine, but likely that these drugs would have a class effect, and they can improve sleep. Of course, they can also have side effects, sometimes confusion, sometimes too much sleepiness, and sometimes a worsening of physical symptoms like tremor. Tricyclic antidepressants, we've kept mentioning those, and they're used for depression, but can have those side effects we mentioned earlier, confusion, dry mouth, and one has to be a little bit careful about their use. And finally, again, dipping into the literature in Parkinson's disease, good evidence in Parkinson's disease patients with depression that even telephone counseling with cognitive behavioral therapy can help reduce the level of mood disturbance in these patients. So again, although this is literature from Parkinson's disease and we have very low levels of evidence in multiple system atrophy, I think we should take this very seriously, because it's likely that these non-pharmacological approaches can be very beneficial and of course come with less side effects. So in summary, the non-motor symptoms in MSA, I think, are very common and may be more burdensome than the physical symptoms. They often coexist, so it's common that you'll see bladder and bowel and blood pressure problems in the same people. One treatment doesn't fit everything. In fact, treating one thing may worsen another, as we've talked about, but they mustn't be ignored, because as I've hopefully pointed out, there are a range of things that we think may be beneficial, and there are lots of helpful things we can try. I finally put up this slide of my team from 2017, celebrating the 200-year anniversary of James Parkinson's essay on the shaking palsy, to remind me to thank them for all the hard work that they do to allow me to come and give presentations like today that I hope you all have found helpful and useful when you're speaking to your own specialists. Thanks so much indeed. I'm very happy to try and take some questions.